Hello, everyone. Welcome to today's webinar. We're so glad you can join us today. Before we get started, I do have a couple of announcements about some upcoming webinars that you may be interested in. On Wednesday, March 20th, we have Patient Handling Hazards and Prevention with Dr. Danya Kidal and the University of Cincinnati Education and Research Center. And on Wednesday, March 27th, we have a webinar on workplace mental health, embracing a population health framework with Dr. Leslie Hammer in the California Labor Lab. And on Wednesday, April 3rd, we'll be having a 1.5-hour presentation online on climate change and human health, an Alaska perspective with Dr. Jeffrey Demain. And this presentation will also be available for continuing medical education credit. For more, you can visit us online at cueh.berkeley.edu/aboutce. And without further ado, it is my pleasure to welcome you all on behalf of education and research centers throughout the country. It's my pleasure to present our Industrial Hygiene webinar series. This is a collaborative effort on behalf of each ERC's continuing education program and aspires to provide access to current research supported through NIOSH ERC programs. Thank you all so much for joining us. Today's webinar, An IH Approach to Assessing Transit Operator Exposures to Fentanyl and Methamphetamine, is brought to you by Dr. Marissa Baker and the Northwest Center for Occupational Health and Safety. A few housekeeping items before we get started. You are going to be muted during this presentation. If you'd like to ask a question, please enter it into the online Q&A box. Now note the Q&A is a little bit different than the chat, so please do try and put those questions in the Q&A. It makes it easier for us at the end to address as many questions as possible. And we will be saving time at the end to answer your questions. This presentation is being recorded and will be made available on the Center for Occupational and Environmental Health YouTube page within 5 business days. And all participants who logged in with their registration email for the full live presentation today will receive an email tomorrow with a link to an evaluation form that will qualify participants for a certificate of completion worth 1 continuing education contact hour. Once the evaluation is completed, you'll be able to access and print your certificate. And it's my pleasure to welcome our presenter today, Dr. Marissa Baker. Marissa Baker, PhD, is an assistant professor of occupational health in the University of Washington School of Public Health in Seattle, Washington. Trained as an industrial hygienist, Dr. Baker has expertise in workplace exposure assessment, using techniques including air and surface sampling, biomonitoring, employee surveys, and exposure modeling. Dr. Baker led a novel exposure assessment in the Pacific Northwest to characterize airborne and surface concentrations of fentanyl and methamphetamine in trains and buses, working with 5 transit agencies. And that is what we're going to be looking at today. Thank you so much for joining us, Dr. Baker. We're excited for your presentation.
Perfect. Great. I'll go ahead and share here. Okay. Nice to be here today. I want to acknowledge my co-authors on this project who are listed here, Mark Boudreau, Christopher Zeidema, and Pranav Srikamp. And I also want to acknowledge the funding for this project. It was funded through a contract with Sound Transit, but other transit agencies, including King County Metro, Community Transit, Everett Transit, and TriMet all contributed funding toward this assessment. But despite that, the findings reported here are those of the authors alone, and they do not necessarily reflect the official views or positions of the agencies who contributed the funding to this assessment. So just to kind of paint a big picture, what motivated this project, which is an exposure assessment looking at secondhand exposure to fentanyl and methamphetamine. This really came from the operator. There were over 1,500 complaints from transit operators in one Seattle agency, in one of the 5 agencies that we worked with in 2022. And that was coupled with some viral news articles in Seattle and Portland, and you might have seen them in other parts of the country as well, kind of fueling the outrage around this, showing some firsthand perspectives from operators and the public who had encountered drug use on transit. And so between the complaints and between some of the kind of news media attention on this issue, the transit agencies actually reached out to researchers in my department at University of Washington, the Department of Environmental and Occupational Health Sciences, with questions around ventilation, around cleaning, and that kind of snowballed into a more formal exposure assessment, which I'm going to describe here. So as a big overview of what we did, we undertook an exposure assessment for fentanyl and methamphetamine on transit vehicles in the Pacific Northwest. We collected both air and surface samples and analyzed them for fentanyl and methamphetamine. And in total, we collected samples from 11 different buses across 2 agencies and 19 train cars across 2 agencies. And we collected these between March and June of 2023 over 28 different nights. I want to stress that the agency partners helped us identify the routes, the runs, and the time of day when smoking of these substances would be most likely to occur. So we were trying to find the buses and trains and sample during the time of day where we would be most likely to encounter drug use. So certainly what we're presenting is not representative of every single train car or every single bus in the Puget Sound area. While we can't be sure that what we found was worst case scenario, we were looking for exposure events and worst case scenario. Consistently, we collected air and surface samples at or near the operator to try to assess the worker exposures that they are facing, but we also collected samples throughout the vehicle, you know, in the back of the bus, in the passenger area of the trains, in areas where we thought smoke would be expected to accumulate or where we thought the source of the smoke would be coming from. I also want to stress that there are some things that the assessment did not do. So first, we did not characterize any short or long-term health outcomes associated with secondhand exposure to fentanyl or methamphetamine. So this is an exposure assessment. We did not couple that yet with any kind of assessment of health impacts. We also did not collect any internal biomarkers of exposure, such as urine or blood, from the operators. And the reason why is it was hard to come to kind of an agreement for all parties feeling enthusiastic about this. There were concerns that if we found it, then there would be, you know, we wouldn't know if it was from use or from secondhand exposure. There were concerns that if we didn't find it, then that would mean then it would be considered not a problem. There were also just logistical challenges with thinking about, you know, interrupting routes in order to collect a urine or blood sample that would be appropriately timed. You know, so this is something that maybe would happen in future work, but did not happen in this work. There were several challenges to confront just right off the bat for this project. One is there are no enforceable occupational exposure levels that are specific to these contaminants, that are specific to fentanyl in the air or on surfaces, or methamphetamine on the air or on surfaces as occupational exposure levels. So that already sets up a challenge of whatever we find, what are we going to compare it to? There are also, you know, you can't go and find a DEOHS method for how to best sample for these contaminants. They're kind of informed by other researchers who have done this, and by Bureau Veritas, who is the lab that made the sampling media that we used. Also, our sampling equipment couldn't be visible or accessible to the riding public. So it kind of became a challenge to make sure we could hide our sampling equipment on transit, so it would still be in a place that we wanted it to be without it causing a disruption to the public. We also quickly learned that researchers being on transit with our equipment could induce bias in terms of activities that people were engaging in. And so that kind of resulted in us not being on the transit with our equipment, which made it kind of challenging to determine the circumstances of exposure. So if we measured something, we don't know when that happened, how long the smoking event was, where the person was when they were smoking. So it, made some interpretation much more challenging. So I'm putting this all up front as some of the caveats. So when you see the results, you can keep these in the back of your mind. So there are some health-based guidance values that I would also like to mention just to kind of frame our results and give us something to compare our results to. So a reminder that there are no enforceable airborne or surface standards for fentanyl, but the ACGIH has written TLVs. They've written 2 for air. They've written an 8-hour inhalable time-weighted average TLV of 0.1 microgram per cubic meter. And they've also written in a short-term exposure limit, a 15-minute STEL, which is 0.2 micrograms per cubic meter. These actually formally came out with the 2024 TLVs, so these are brand new. ACGIH also wrote a surface limit of 10 nanograms per square centimeter. Again, this came out after we had collected all of our data, but it's still, useful to compare to. When we were doing our study, we kind of operated under the general consensus of decontaminating as low as reasonably achievable for both air and surface. For methamphetamine, it's slightly different. There are no guidance values either for air, whether that's regulatory or guidance. We do have some surface regulatory values, and they differ between states, and it's also unclear how applicable these are to transit. In Oregon, the acceptable level for decontamination is 0.54 nanograms per square centimeter, but it's of note that this applies only to drug manufacturing sites and is explicitly not applicable to transit. So it's a number we can compare to, but it's not something that the agencies would have to comply with. In Washington State, the acceptable level is 15 nanograms per square centimeter. The applicability to transit is a little bit unknown. It hasn't kind of been tested in the courts. It's meant for known drug labs or transient accommodations, but we're still using it as kind of a benchmark for comparing our surface methamphetamine levels to. Okay, so now you get to see my artwork, and I kind of want to explain the exposure profile that we're dealing with for these events. So along my x-axis there at the bottom, I have the time, and I have an 8-hour work day there. Along the y-axis is exposure. Let's say fentanyl exposure in units of micrograms per cubic meter. It's important to note that these smoking events are not consistent. They are very short, and they can be very infrequent, which is shown here. So this is somebody smoking, and it takes maybe 15 minutes, maybe 2 minutes. They're very short smoking events, but they can generate, a large amount of exposure from those short events. So when we're looking over an 8-hour time-weighted average exposure, it is averaging all of those smoking events over that work shift. And there might only be 1, there might be 4, there might be none. It varies. And that's kind of how we think about the operator exposure. But when we're talking about the riding public, of course, the riding public is not on the bus for 8 hours or 10 hours like the operators are. They might be on the bus for a half hour, and that's denoted here by this blue bar. And so it really depends on if the operator happens to be on the bus when one of these events is happening as to whether or not they would be exposed. So for example, this person, they got on the bus and no one was smoking, and then they got off just as someone started smoking. But you could have a scenario where someone happened to get on and directly overlap with the time someone is smoking, in which case they would have a much higher exposure than the previous rider. And similarly, you could have someone get on the bus and never encounter a smoke use event, even though the driver would encounter multiple over the course of their shift. And the reason I go through this is just to reiterate that we did full shift sampling. We did not sample for short-term events. What we collected is not applicable to the writing public. And if we had been wanting to assess the exposures of the writing public, we would have done a much different exposure assessment campaign. This is to assess the workplace exposure, the exposures the worker would face, averaged over their shift. So keeping in mind that someone riding the bus could experience, no exposure. They could have much different highs and lows, but they would be on for a much shorter period of time. So to get into a little bit more detail of the methods we used. So starting with the air samples. They varied, the air samples, the location, the number, the timing of the samples varied by the agency and the type of vehicle. And I will go into a little more detail about what those variances were. But we did consistently collect a sample representative of operator exposure, either by putting a sampling pump on their seat with the filter hanging into their breathing zone, or putting a pump in the cab of the trains with the filter in their breathing zone representative of the air in the cab. And then we collected other air samples throughout the bus or train. As I mentioned, the pumps needed to be hidden, but still accessible to researchers, and I'll show some pictures of how we managed that. And we aimed to collect all air samples for 4 hours, but not more than 4 hours due to recovery drop-offs with the lab. And we used these 4-hour samples to inform 8-hour time-weighted average exposures. Just some pictures of our setup here. We used SKC AirCheck 5000 pumps, which we calibrated to 2 liters per minute, as shown on the left picture there. These were connected to 25 millimeter, 5 micron nylon filters in 3-stage, 25 millimeter black polypropylene cassettes, for those who are interested in the technical details. And you can see a picture of that on the right. And we did collect blanks on each sampling day, where we, carried the filter head with us in the same manner, the cassette with us in the same manner, but did not pull air through them. Similar for the surface samples. Again, this varied some by agency and type of vehicle, but we did consistently collect a surface sample near the operator. On buses, this was collected on a shelf by their seat. We wanted to find a settling surface, but on the trains, these were the doors of the train cab going into the operator cab. And then we collected other wipe samples in both predetermined and pre-cleaned areas throughout the coach or train. I want to stress that, so we went in, when we set up our equipment, we cleaned a spot. We pre-cleaned it using IPA, Luminox, and then at the end of the shift, we took a sample there. And so really what we were measuring with those samples is how much drug residue deposited on these surfaces during the work shift. Also, kind of fueled mostly by curiosity, we collected other wipe samples from areas where we did not pre-clean. So if we found paraphernalia, like foil or a pipe, we might wipe that. We wiped some high-touch surfaces, such as handlebars that people would grab onto. And we also did some sampling in the ventilation system, kind of when we saw what was in there. And so these samples are really asking how much drug residue has deposited in this location since a previous cleaning. We did not typically know when the previous cleaning was. So there's a couple differences in the surface samples there. Here are some pictures, a little blurry for some reason, of our surface sampling equipment. So what we did is we rubbed a methanol wetted swab over a 100 square centimeter area. So we had a 10 by 10 centimeter template that we used. After we collected that swab, which is shown on the right there, we stored it in these capped glass containers. And we also collected blanks on each sampling day, where we dipped the swab into the methanol and then put it directly into the glass container. Of course, it can be challenging to collect a surface sample on an uneven surface or on a more porous surface. So we did try to focus on the harder surfaces, plastic, metal, things like that. All of our samples were sent on dry ice to the Bureau Veritas lab for analysis via their OP alert method. And for that, they used LC-MS-MS. And just as a note here, the main reason we sought an external lab is that a lab that we commonly work with at the University of Washington in our department did not have the FDA clearance to buy fentanyl and methamphetamine standards. And we were ramping up and moving quickly, and we didn't have time to go through that certification process. So we did seek an external lab who could do this analysis for us. We have since been working with a lab in our School of Pharmacology who does have the ability to buy these methods for us. So we're hopeful any work we have going forward, we would be able to do in-house at the University of Washington. As I mentioned, reported recovery for methamphetamine and fentanyl decreases after 4 hours of sampling. And this was information that Bureau Veritas told us. So you're only recovering 70 to 80% of fentanyl after 4 hours and 85 to 99% of methamphetamine. We did not correct any of our results for recovery. I will say that a quarter of our samples, our air samples, were collected for 4 to 5 hours, so more than 4 hours, but not 5 hours. But all the other samples were collected for less than 4 hours. So there might be some underestimates, particularly for fentanyl and some of the longer samples, but overall we feel comfortable that we were in a range where we were able to recover most of what we were looking at. Okay, so this is a big table and there's a lot to take in, and I'm not going to go through every cell, but this basically outlines the different sampling strategy we used across the 4 different agencies we worked with. And we worked with 2 train agencies and 2 bus agencies. And I'm going to draw your attention to 2 just to explain kind of some of the differences. So these buses that we sampled on 1 bus, but we did it for 15 different nights. So you can see we sampled for a total of 15 shifts, but it was all on the same bus. And it was a bus that was identified to go on one of the kind of higher risk routes. And the main reason we kept it all on this 1 bus was because we had to retrofit some parts of it for our equipment. And you can see that, we sampled for 4 hours. We had our pumps timed to turn on at 7 p.m. and turn off at 11 p.m. And you can see we were able to collect 4 different air samples, 1 on the operator's seat, 1 kind of mid-bus behind the electronic reader board, and I'll show a picture, and then 2 in the rear of the bus. Contrasted to sampling we did on the other bus company we worked with. Here, we only sampled for 2 shifts, but across those 2 shifts, we sampled on a total of 10 different buses. And so we set up our equipment on 5 buses on one day, and then 5 buses on another day. So you can see that there are some differences. With one agency, we sampled 1 bus 15 times. On this agency, we sampled 10 different buses. And we only had, on this bus, we only had 2 air samples, 1 on the operator's seat and 1 in the rear of the bus. And the sampling times also varied here because we set them up, let the bus do 2 full routes, and then took them down. And so the time of the sample varied. So just to show you that there was not a consistent strategy even between the buses and between the trains. And it was, based on what we were allowed to do with the agencies, kind of the restrictions around operations and things like that. We did not want to disrupt operations. We also didn't want to disrupt riders. So here are some examples of how we kind of concealed these pumps and filters on the buses. So on the far right, you can see where we have the pump set up on the operator's seat. We did this on all the buses so we could get a sample that's fairly representative of the operator. In the middle at the top, you see we had this little magnetic box that we concealed our pump in that we could hide behind the reader board. And luckily no one seemed to notice. It was not taken. Below that, I talked about, fabricating some panels. So this is in the very rear of the bus. and someone on their engineering team fabricated a panel that we could put back there with this little circular vent that, we thought looked like a speaker, so it wouldn't necessarily raise attention. And so we're able to put this on both sides in the rear of the bus. On the far left, we did resort to putting filters in the ventilation system on one bus. This was kind of the only place that we were able to conceal the equipment on that bus. So here's just some examples of how we had to be creative and to hide this equipment. And then similarly, here are some some examples from the train, and I'll kind of walk you through this. So looking at this train on the left-hand picture, and luckily the trains were the same between Seattle and Portland. They both operate the same Siemens trains. What you see in blue there is the door, and that door is separating the operator's cab from the passenger area. So we fabricated this black panel that goes in the window, and then we could put a filter pointing out through that window. And you can see it connects via the tubing into the pump, which was then hidden away in the operator cab. So this allowed us to measure air in the passenger area. And then similarly, we put a pump and filter in the operator cab, which is obviously much easier to conceal. So that's how we sampled on trains, by fabricating this panel that we could put a filter through facing outward. And there's our team down in Portland collecting data last summer. All right, so moving into the results, what we found separately for fentanyl and methamphetamine and air and surface samples. So here are the air sampling results for fentanyl in air. And I want to highlight that fentanyl, we are comparing these to the ACGIH TLV of 0.1 micrograms per cubic meter. And note that that is inhalable. We did total dust sampling. We know that total dust does underestimate inhalable. However, it is the smallest particle sizes that we're most concerned about from a health standpoint. So we are comparing them here. So this I have broken down by bus and train, by those collected at the operator and those collected in the rear of the bus and in the operator cab and in the passenger area of the train. And you'll see that we did not find fentanyl on every sample. Overall, we found fentanyl on about a quarter of the samples. You can see in the second column here, or I guess the third column here. And on average, our samples were below the fentanyl ACGIH TLV. We did have one sample in the passenger area of the train that did exceed the TLV with a 0.14. And we had another sample that was at about 80% the TLV. So certainly higher than half the TLV, which is when we might get a little concerned. And that was in the operator cab. And it was the same time we were collecting the high passenger sample. And in general, the exposures tended to be higher in the rear of the bus, tended to be higher in the passenger area of the train. But in the, we were only able to detect fentanyl at one of the operator samples we collected on the buses of the 14 we collected. And I will note, we did not submit for analysis every sample that we collected, and that was driven by budget. The analysis was not inexpensive, another reason why we were looking to develop an in-house analysis. And so we had to kind of prioritize the samples where we think something happened based on finding paraphernalia at pump pickup, whether it's foil or a Narcan box or a pipe, which frequently we did find, or if the operator thought something happened. We didn't necessarily have a lot of interaction with the operator because when they get done with their shift, they're ready to go home. But if they indicated to us that, they smelled something or saw something, then that would make that a sample we would be more willing to analyze. And then here are the methamphetamine results. As I mentioned, unfortunately, we do not have a standard to compare these to, but I did want to highlight the fact that we found methamphetamine in every sample that we submitted to the lab. So we found it in 100% of samples, regardless of whether it was at the operator or in passenger areas. Also, I want to note here that our fentanyl and methamphetamine levels that we found were not correlated, which leads us to think that there could be different determinants of exposure. Maybe a lot of what we think is fentanyl use is actually a different drug, but that they're not necessarily being used together consistently. So to put all of what I've said into bullet points for you, we submitted 78 air samples for analysis, and a quarter of them had detectable fentanyl and all of them had detectable methamphetamine. Just because something is detectable does not mean that it is going to cause a health outcome, but it was detected. We had one air sample that exceeded the ACGIH TLV for fentanyl in inhalable air, and that was found in the train passenger area. The next highest sample was 0.078 micrograms per cubic meter, about 80% of that TLV, and that was an operator exposure. Exposures were higher in the rear of the bus or in the passenger area. This is consistent with areas where use is most frequently reported, but there was evidence of migration to the operator. As a note, these valuables are not interpretable for the writing public. They are averaged over an entire work shift, and they are not representative of a single short-term exposure. But the question is, what if they were a representative of a single short-term exposure? We do not know, but what if these samples did represent a single, 15-minute smoking event, like I showed on my picture at the start? So what we did, and this is just the back of the envelope, not something we would try to send through peer review, but we took the total masses in nanograms of fentanyl that we received from the lab. We divided that mass by the air that would be pulled through our pump in 15 minutes, which would be 30 liters of air, to see if, under the assumption that these findings represented a single smoking event, would it exceed the 15-minute ACGIH STEL? So again, we don't know if it's only one smoking event or multiple, but it's certainly not out of the scope of possibility that it could be only one smoking event. And doing this exercise, 7 of our 20 fentanyl samples exceeded the STEL, and the highest calculated STEL was 2.2 micrograms per cubic meters in the passenger area of the train, but we had STEL exceedances across all agencies and locations. And so while there's a lot of unknowns in this very kind of rough calculation, it certainly brings up an area of ongoing research that we'd like to explore, is kind of what levels are generated in short-term for a rider, for someone who's only there for 15 minutes, what level of exposure occurs from a single smoking event, things like that. Okay, moving on to our surface samples. And here you can see some pictures of staff, university staff and agency representatives collecting surface samples. So in the middle, we have Mark here collecting a sample from a high touch area, which is a handlebar that someone might use as they're getting on or off the bus, or just hold on to for stability. Lily here on the right is collecting on the back of a divider. This is an area where we were told people will sometimes sit to smoke. So we were checking those areas. And here's a picture of me collecting a sample in the ventilation system. I kind of teased this earlier, but when we were pulling down the ventilation to put pumps up there, we noted that it's kind of gunky up there, and we referred to this as the black gunk. So we did take some surface samples here to see if there was drug residue that was kind of persisting in the ventilation system. And here's what we found from all of that. Of the 102 surface samples that we submitted for analysis, 47 had detectable fentanyl. The highest levels were on the paraphernalia, which is not a surprise, but also on the door handles, the picture I showed before, and in the rear of the bus. Of the 102 samples we submitted, nearly all of them had detectable methamphetamine. And that was actually highest inside the bus vents, like on the picture I showed to the right, and also in the passenger areas. Some wipe samples exceeded the state decontamination guidance for methamphetamine, and those were ones that were collected inside the bus vents. And if you look to that picture on the right, you'll notice that the sample I collected was not a complete sample. I removed kind of the first layer of the gunk. So certainly it's an underestimate probably of the total on that surface. And these exceeded quite handily. No fentanyl samples, even those collected in the vents, exceeded the ACGIH surface limit of 10 nanograms per square centimeter. The highest sample was at about half of that, and it was actually the sample collected from the door handle. So we're still kind of worth thinking about how to clean that based on the ACGIH surface limit. We also collected background samples across Washington and Oregon, and these were repeat environmental air and surface samples that we collected from suburban areas, urban cores, urban neighborhoods, in order to see how the levels we found on transit compared to kind of just levels in the general Seattle and Portland metro areas. And you can see some pictures of how we did that. It was a lot of, again, hiding our equipment in a car, hiding it in a wheel well. The one in the middle, we used our magnetic box. That's a University of Washington building. So we collected there in the U district across all these samples. And we took them from 8 different locations, 5 in Washington, 3 in Oregon, and we took them in triplicate. We did not detect fentanyl in any of the wipe samples or the air samples. We did detect methamphetamine in a handful of them, like maybe fewer than 5, but they were about 1,000 times lower than we measured on transit. Now, 1,000 times sounds like it's a huge difference, but we can measure very small amounts. So we were able to measure a very small amount in kind of sometimes in Seattle and Portland, and we were able to measure a slightly larger amount on transit. But from this, we did recognize that it's likely not the external environment that is driving the values we are seeing. It is it's events that are happening on transit itself that's driving these levels. So our conclusions, in general, the levels that we found on transit are unlikely to cause acute short-term physical health effects for the riding public who spend less time on transit than the operators. And we feel comfortable saying this because there haven't actually been any reported cases that we were able to identify of a rider having an acute effect from someone smoking. But the potential for physical or mental health effects related to low-level daily secondhand exposure to fentanyl and methamphetamine should be considered for transit operators, given that they can spend 40+ hours each week on the bus or train and might have these kind of low-level chronic exposures. The long-term health effects related to daily secondhand exposure to these substances has not been established. So in the absence of data relating the exposure and health outcomes, we recommended protective measures to keep operators safe. And we recommend using these protective measures to reduce exposure to the lowest level that is reasonably achievable. So what were the recommendations that we made to the agencies? So first, to continue to work with the relevant partners to address drug use on transit. We do not feel that drug use should be tolerated on transit. However, we do also think that a harm reduction approach is warranted. And so continuing to work with public health agencies, substance abuse agencies in order to, figure out how to get this activity off of transit, but still provide supports for the vulnerable population who is using these drugs. We also stressed that the agencies need to liaise with the unions and the workers for input into the response and controls. We learned that the operators have opinions and ideas and very real lived experiences. And if the agencies liaise with the unions and the workers, they'll have more buy-in and it will go better for them. We also suggested upgrading ventilation to MERV 13 filters on all buses and trains. And in fact, most of the agencies have completed this or are currently working on this. And this has the co-benefit for infectious disease control and also wildfire smoke control. We suggested enhanced cleaning protocols, increasing the frequency of cleaning, using solvents that are appropriate for both water-soluble and insoluble materials, and doing an emphasis on more frequent deep cleaning, like even getting up into the ventilation system. Now, granted, an operator or a rider is probably not going to get in the ventilation system, but maintenance would. And so keeping, all components clean will protect all the workers who might be on a bus or a train. We also think, we should have operator training and special considerations for operators, whether that's amending their agency protocols for how to report a problem or for how to, get support for an event like this, teaching operators how to keep themselves safe, doing, an appropriate training on what are the real risks, what are the perceived risks, making sure operators can access mental health supports are all very important. The operators have very real, responses to this. Sometimes it's physical health responses, often it's mental health responses. And I think that needs to be acknowledged, and the agencies need to continue to provide supports for those operators. So our favorite hierarchy of controls, I don't know if we can do an industrial hygiene talk without mentioning this. You'll note that I've mentioned controls kind of across the hierarchy, from elimination to engineering to administrative controls. I have not recommended masks, and that was deliberate. We know there's a lot of variability in how masks are enacted. The agencies, would need a respiratory protection plan, have to train the operators. And given that we have so many options on the other rungs of this hierarchy, recommending masks, would have to be a respirator, is not something that we did. Even though DEOHS does recommend masks for people who are cleaning up fentanyl, it's not something we recommended for the transit operators. Okay, so a transit operator walks into an IH's office. Maybe it's you, and they tell you that or maybe it's not a transit operator. Somebody walks into your office and says they were exposed to fentanyl or other smoked drugs in the workplace. So the first thing I would say is you should believe them, because it's present on transit. We know that these things are smoked in a lot of kind of public spaces. And so it is likely true that they witnessed it and were exposed to it. Also, I think it's important to acknowledge that being around fentanyl smoke and drug smoke in general is not remotely pleasant. It smells bad, it's disgusting. And so there can be physical and mental impacts. Things like an overdose from secondhand smoke is not going to happen, but you could feel panicked, you could feel scared, you could feel mad, you could feel frustrated, you could, feel triggered. All of those things happen. And so I would encourage you to consider the full range of impacts that the exposure could have to their work life. Physical impacts, mental impacts, psychosocial impacts. One thing we heard a lot from transit operators is that they might have a former relationship with drugs or a loved one who has a relationship with drugs. And so seeing its use or smelling it can be quite triggering to them. And so I think that that's a population that's important to keep in mind. And overall, what we learned is that operators want to be heard and acknowledged, believed that what they're experiencing is real, and given solutions and support instead of having their experiences minimized. So to just be told, you're fine, you're not going to overdose, these levels are low, does not sit well with the operators when they are dealing with this, day in and day out, and trying to safely operate a bus while also keeping an eye on what's going on in the back. Our results were unsurprisingly picked up by local media fairly rapidly. We actually had a press release. The University of Washington organized a press release where I shared a presentation similar to this one. And it was immediately picked up by the media to varying degrees. There were different spins put on it, from UW dismissing drug concerns to, UW finding there's minimal risk, things like that. So this is a part that I don't think as an industrial hygienist, I was necessarily trained in how to best liaise with the media and how to communicate risks and results. And so something that I should have thought of a little bit sooner with this project, given kind of the outrage that we knew that it would have, that it would cause. And I use the term outrage in the Peter Sandman sense, which I will bring up next. So Peter Sandman literally wrote the book on effective risk communication for industrial hygienists. And he's the one who coined the idea that risk, to the general public at least, is really hazard plus outrage. And he said, if people are outraged because they do not understand the hazard, educate them about the hazard. If they are outraged and do understand the hazard, you must address the outrage. Educating the public is not sufficient to deal with public outrage. His book is available for free through AIHA. I suggest looking at it if you are ever going to do any risk communication. And so really, I think that what could have been done better for our risk communication is kind of managing this outrage. The outrage that the operators are feeling, the outrage that the public might be feeling, and holding that outrage a little bit more instead of trying to share what the levels are and how the levels compare to ACGIH standards and things like that. Peter Sandman has coined outrage factors, and these are emotional factors that influence our perceptions of risk. And I've just pulled a few here that are really kind of clear in this situation for operators. So for example, voluntariness is an outrage factor. And risks that are involuntary or imposed are less acceptable than risks from voluntary activities. And certainly that's how operators felt. They felt like these risks were not voluntary, not something they signed up for, out of their control, not fair that this is happening to operators, but it's not happening to other workers. To some, it feels morally wrong to see open use of drugs. The process might have felt to assess the risk and kind of control the risk might have felt inadequate to them. And there was a lack of trust with some of their employers around these risks. So really, looking now, we can see that outrage was the expected outcome of this. And so thinking about how we could have managed that earlier in the process might have helped how we communicated the results. And Peter Sandman reminds us, never say anything is safe. X may be safer than Y, or pretty safe, or safer than it used to be, or safer than the regulatory standard, but it isn't safe, and it certainly isn't absolutely safe. And this is something that we, as researchers, tried to stress, is that the levels are unlikely to cause immediate acute problems, but we don't have enough research to know how harmful this could be over a working lifetime. So just to wrap up, we still have a lot to learn and a lot of potential avenues of research in this area. So one, what levels of secondhand fentanyl could result in a short-term or chronic health outcome in a diverse population? And this, when I'm talking about a short-term outcome, it's not necessarily an overdose. There are a lot of health outcomes between nothing happening and an overdose that we should be thinking about. A question that came to us a lot from operators is how exposure to secondhand drugs in the workplace could impact, employment drug screens. Fentanyl is not currently on the U.S. Department of Transportation screen, but there is still a lot of concern around job insecurity, around getting fired, if it becomes positive for something they were exposed to secondhand. We're also interested in how these exposures and how witnessing these events has been impacting the well-being of transit operators and what interventions transit operators would like to see. And this is something we are actually actively working on through a survey with the Amalgamated Transit Union, who represents these operators. We also want to assess potential interactions between drugs and their health impacts. These are things we measured. We measured fentanyl, we've measured methamphetamine, but drugs are often used as a mix, and so the interactions are important. We also want to do more characterizing short-term exposures. It's a challenge, though it feels like it would be a challenge to measure, given that being there with our equipment, may induce a bias into even being able to witness these events. And then lastly, how to better verify the determinants of exposure. So what do our numbers mean? Was that one smoking event? Was that multiple people? Was it multiple events? Was it right next to our filter? Was it far away? Would help us give some context to our findings. But the most important thing I learned, which you should all take with you in your career, is don't read the comments. Nothing ever good comes from the comments on Twitter or on news sites. So it's just don't read them. Stay out of the comments. I'll wrap that up with acknowledgements to all the folks that we worked with. In particular, I want to give a big acknowledgement to Mark Boudreau, who was the CIH who assisted this project. But there were lots of faculty and staff contributing. My contact information is there. We do have a final report that that may answer all of your questions. And with that, I'll turn it over to Michelle for the Q&A.
Well, thank you so much for your presentation and for also doing this research. I hope you can see the reactions coming through in the Zoom window. We've got lots of clapping and thumbs up. So thank you so much for sharing this. At this time, if you have questions, please do go ahead and enter them into the Q&A. I'm going to go ahead and we've already got a lot of questions in here, so I'm going to go ahead and start working my way through them now. But please go ahead if you have questions, you can enter them there. First question, did you sample the surfaces immediately after cleaning?
We did for some kind of testing of our cleaning protocol, but in general, we cleaned the surface and then we, went and tested it after a work shift. So it would have been exposed for the work shift.
Thank you. Also, fentanyl seems to be a solid with a pretty high boiling point. How does it get airborne?
Yeah, it is a solid often, and it does have a high boiling point. But with heating it on a foil with an open flame actually causes it to get above its flash point, and it can aerosolize into the air and be airborne. Most of it is in particulate form, so it's very small particulates in the air, suspended in the air. A very, very small amount of it might be in the vapor phase, but fairly negligible amount.
Thank you so much. Was the sample team able to evaluate the airflow in the buses and trains?
There was, in some ways, yes. So we did some ventilation assessment of buses and trains, but not concurrent to when we were collecting the samples. So we were able to go in and we used some beekeeper smoke, tried some different filters to see how MERV, 11 versus 13 worked, how long it took. We're trying to calculate air exchange. It's during use, obviously you can't control, like people will open windows, operators will open windows, and on the trains, actually, the ventilation parameters adjust automatically based on train capacity. So we were able to do some experimental assessments of that, but not concurrently to when we were collecting samples.
Thank you. We also have a number of questions and comments regarding cameras on buses and trains. Both, could you use the data of the cameras and if there were cameras available to determine potential exposures? Does that raise any privacy issues? Do cameras provide a possible deterrent for users? Could they be used to narrow down specific high-use areas on times or buses on trains? If you could speak a little bit to what you observed regarding cameras, that would be great.
Yeah, so all the buses and trains do have cameras. And from what I learned from the agencies, by getting onto a bus or a train, you are consenting to being recorded. And so in some instances, we were given access to cameras. It's hard to, you might see kind of a grainy person slumping over. It's hard to definitively determine if someone is smoking. There were a couple instances of people who would get on and we could see them like sit in very specific areas, the one area that the camera doesn't catch. And I don't know how a general member of the public would necessarily know where that area is. there were a couple instances where cameras for one agency were useful with understanding, like we would see people, we saw someone get on and we saw them close the windows, which is usually a sign they're trying to create less airflow for smoking. And then you could kind of see maybe a plume. One of the researchers on this project had the idea of doing thermal cameras as maybe a way to kind of see where are the heat events coming, because obviously these are very high heat events. That's not something we were able to test, but it does seem like something that might be useful. And, then there would not be any identifiability concerns. And we could have an idea of where it's happening, when it's happening, things like that. So the cameras were, that was our original plan. And we had agreements with the agencies to have access to cameras and things like that. It just did not end up being useful in practice consistently.
Thank you so much. And we've also got a few questions related to the unionization of transit workers. Are operators unionized? If so, what has been their reaction? And were you able to connect with them about your study design?
Yes, so the operators are unionized. In this region, the Puget Sound is the largest ATU chapter on the West Coast. They are unionized with ATU, which is the Amalgamated Transit Union. They were very involved in our study design. We had monthly meetings while the project was ongoing, which had members of the agencies, the research team, and union representatives who attended to kind of get an idea of what we were doing. And the day of our press release, the research team went down to the union meeting to kind of hold some of the outrage that they were feeling. In general, I think the operators feel maybe a too little too late, and that there's more concern about the writing public than there is about the operator themselves. So we're hoping that this survey I teased with the union will help to kind of bring, and we're doing a qualitative component to that as well, will help to kind of elevate some of the voices of the operators, so we can learn more about what they're feeling and hopefully elevate that out to not only their employers, but also the communities.
Great, thank you so much. We also have a couple of questions related to the TLVs. What is the basis of the TLV if there's not enough research on the health effects of chronic low exposure to fentanyl?
Yeah.
Are you able to describe the basis for the TLVs and STELs for fentanyl?
Yeah, a little bit. So if you're an ACGIH member, you can access the full documentation that went into developing these TLVs. It's largely from animal studies for the inhalation. For the surface levels, and there were a couple studies, and these you don't need any documentation to access, that were done in the pharmaceutical industry. So in labs where where fentanyl is made for use medically, whether it's pills or for IVs, it has a very important medical use. And for that study, they actually people all wore very good respiratory protection, and they measured fentanyl in their urine, and they still found it. And so it was really, and they did like wipe sampling and dermal sampling. And so that study concluded that, dermal at a certain level did still make it into their body and kind of increase their body burden. So those are some of the studies that they used. The pharmaceutical study is interesting for a lot of reasons, because it's a exposure assessment in a place where the exposures would be assumed to be high, but also where people are under very strict protocols for PPE and for protecting the pure pharmaceutical grade fentanyl, right? Yeah, so those are, I would encourage you to look at the full documentation if you're able to. It's light. It feels light. And the TLV, that 0.1 value, that was a value that was also actually proposed by the pharmaceutical production industry as a level to keep production workers safe. And so I think that number likely informed. And then typically, often a short-term exposure limit is double the 8-hour TWA.
Thank you, thank you. We have a lot of questions here. I don't think we're going to get to all of them, but I am going to raise up a couple of more here. Um, just a quick note about what impacts do you think these findings might have for children getting around these forms of transportation?
Yeah, so we know that that there are other routes of exposure to consider. There's the hand to mouth route to exposure, which is very important. And, as you'll see, we did find this on shared surfaces. So I do think that, and children obviously are smaller, and these TLVs that we compared to are for a assumed healthy working population, adults. So I do think that, that there are vulnerable populations such as children that would need to have more of an exposure assessment done. Our exposure assessment was for the workers. And so it's not directly comparable to riders. It's not directly comparable to children. But I would say that, because children are more likely to do hand to mouth, they might be more likely to touch more surfaces, to move around more in different places, that kind of would need to, that is certainly a population that would deserve more attention for these exposures.
Thank you. Absolutely. Are there any other occupational groups who might also be worth considering for these types of hazards?
Yeah, certainly. So as we've been doing this work, we have heard of other occupations that, face exposures. Apparently the bathrooms in libraries is often a place where people may smoke substances, or in hospitals as well, particularly like in emergency room bathrooms and things like that. I've heard about it. Some in people might go into a parking garage, and so like security guards who are in there, or people who are in and around the parking garages. Of course, we've heard about it with first responders, police officers. So there, yes, there are, or people who interact with the public in those types of ways. Yeah.
Thank you. And we have reached the top of the hour here, but I just want to invite everyone. There are some questions we didn't get to today, but kindly, Dr. Baker has put her email address up on the slide here. You can also visit, I put that link directly in the chat, so you can also visit that link and go ahead and review the final report as well. Thank you all so much for being here. We really appreciate your time, Dr. Baker as well. Do you have any final thoughts or closing comments that you'd like to share with our audience today?
No, well, I peeked up to one of the answers, and I saw someone ask, would you want these levels in your office? And no, of course not. I don't want anyone smoking in my office. It is disgusting. It's not enjoyable. Even getting on a bus after someone had smoked, I could smell it in my hair for the whole day. It's just so, and one operator, said to us, could you imagine somebody smoking fentanyl on a plane and them saying, well, it's okay because the pilot is behind a door. And that kind of, it's an extreme example, and I know that there are differences between plane travel and bus travel, but I think it's important to just acknowledge that it's unpleasant. And even if it's not going to give you an overdose, even if it's not going to, it's still unpleasant, and it makes it hard for the operators to do their job safely. And there are solutions that can be both supportive of the health of the drug user and the health of the transit operator. And those are the solutions we need to be prioritizing.
Well, thank you again so much for your time today. Thank you for your very important research. And thank you to all of our attendees who joined us live. As a reminder, this presentation was recorded, so you can check back on our website and YouTube page in about a week from now in case you'd like to review the presentation again or to share it with anyone who might find interesting. So thank you again for your time today, and I hope you all have a wonderful Tuesday.